Thank you everyone for making time to join. We will be going over the results of our post-COVID-19 study with LDN and NAD. And to guide us through that is our co-founder and chief medical officer, Dr. Sajat Salsala, also known as Dr. Z. So I'll let you take it from here, Dr. Z. Thank you.
Okay, well, thank you everybody for joining us, and thanks for the introduction. So today we're going to be talking about the publication that we recently published based on a pilot trial that we finished. And it's the pilot study looking at using low-dose naltrexone and NAD with for treating patients with post-COVID or long COVID syndrome. All right. So just a quick intro. My name is Sajat Salsala, Dr. Z for short. I'm the co-founder, chief medical officer of AgelessRx. I've extensive telemedicine background, and of course, I've been interested in functional medicine for a long time. And a kind of a natural extension of functional medicine is longevity medicine. So the first several slides are similar to the slides that I presented. It's been about 2 or 3 years. We did a webinar when we kicked off the trial 2 or 3 years ago. So if anybody's watched that webinar, these first few slides are going to be similar because they give good background information about what is long COVID, and then why we decided to study it, why we decided to try to do a pilot trial about it, and also what are some theories behind it. So basically long COVID is a syndrome that occurs after getting in this, it's a post-viral syndrome. So in this case, the virus is COVID. It's not unique to COVID. There are other viruses that can cause post-viral syndromes. But because, the pandemic affected so many people, and at one point there was thought to be about 20% of individuals who came down with COVID who went on to get long COVID or post-COVID. Some people call them long haulers. They're various different names. So you may hear me say post-COVID and long COVID interchangeable. And you might actually see that on some of the slides as well. So basically, plausible causes, persistent viremia. Basically, your body's just not able to clear the virus. And that kind of leads to kind of relapsing of the same infection over and over again. And there's also thought to be this inflammatory component where that just kind of puts a cycle of inflammation, and then of course that inflammation causes dysfunction in the human body, and that leads to a deconditioning because people just don't feel well. They have myalgias, muscle aches, joint pains, all sorts. We'll talk a little bit more about what symptoms people have, and then of course there's some people who have such severe sickness with COVID, there's a little bit of almost like PTSD from having the COVID itself. And like I mentioned before, our interest in trying to do a trial with long COVID came with my personal experience as a clinician treating or trying to treat what's called chronic fatigue syndrome, also known as myalgic encephalomyelitis. And there's a lot of overlap between long COVID, CFS, and fibromyalgia syndrome. So what is it? I mean, definitions vary out there, but basically it's thought to be this syndrome of symptoms that occur, after the acute phase of the virus ends. So with most people who come down sick with COVID, they're sick for a few days, maybe a week or two, and naturally you're supposed to recover, but some people just don't recover fully, and they end up with a variety of different symptoms that include one or more of the following: tiredness, fatigue, ongoing fever, difficult breathing, chest pain, things like that, joint pains, myalgias. So like I said, we originally designed the trial to be a randomized controlled trial with a placebo control. So this is kind of our original trial design. We were supposed to, we wanted to enroll 30 people, split them into 2 groups. And put one group on placebo and the other on control. However, we ran into some issues with recruiting. A lot of the potential participants didn't want to risk being on the placebo, and so once that kind of came up over and over again with potential participants, we went back to our IRB, our institutional review board, said, hey, look, we're having a hard time recruiting. but we want to get the study done. So let's drop the placebo, because that seems to be that was kind of a big non-starter, it seems like, for a lot of people who are potentially. And so we decided to do just a more like a observational group instead of, so anybody who wanted to enroll ended up on the active group, and we dropped the placebo. So actually ended up, we were targeting 30, but 60. We ended up recruiting, I think 36 was our final number. And I'll go a little bit more about kind of the inclusion and exclusion criteria. So one of the big hallmarks of long COVID is fatigue. And so we searched out there and say, okay, how do we measure fatigue? And one of the validated measurements for fatigue is the Chodler's fatigue scale. And we also did a secondary endpoint looking at a more comprehensive quality of life assay called the SF36, the short form 36. Again, that's used extensively in looking at various interventions with quality of life. So the Chodler is a score. It asks 11 questions. You can get a score from 0 to 33. The lower the score, the better for the Chodler. So keep that in mind. And this is one of the sample questions, do you have any problems with tiredness? And then it was like, it's the ranking. And there's a couple other sample questions here. The SF36 is 36 questions total, basically 4 questions across 8 domains. Things like, health, emotional energy, functioning, things like that. And there's some sample questions there as well. Again, it's kind of a ranking, like a ranking, like rank your level in terms of, in this case, how would you say your general health was? So each of these generate a score. The scoring for the SF36 is from 0 to 100, with 50 kind of being what's considered to be average. So if you're above 50, you're considered to be above average in terms of general functioning. If you're below 50 for the SF36, you're thought to be below average. And for the Chodler, we chose a cutoff of 9 because it was thought that a score of 9 and higher is considered to be clinically significant. And like I said, it goes all the way to 33. So, but 9 is kind of where moderate, fatigue starts to kick in. So we included, anybody between the ages of 18 to 65. They had to have been, cognitively intact enough to consent. They had to have been, willing and able to participate in a remote clinical trial and a decentralized clinical trial, because everything was handled remotely. And they had to have obviously had COVID at some point. And first we started out including only people with PCR, because at the time that was really the only thing testing. And then later antigen tests and antibody tests became available. So we kind of expanded our eligibility to that. Like I said, Chodler fatigue 9 or higher, and then willing to fill out the surveys and also willing to use the interventions, which were the LDN and the NAD. Exclusions, we excluded people who are currently on NAD and LDN, who are currently in another clinical trial, who had uncontrolled diseases such as like active cancer, anybody who was pregnant or breastfeeding, or sensitive to any of the medications. If they were taking, for example, opioids, or were undergoing any kind of addiction treatment, we exclude them because of the naltrexone part of it. Let's see. So let me jump into what LDN is. So LDN is short for low dose naltrexone. It's an opioid, what's called antagonist, that blocks the opioid receptors, specifically the mu opioids. It was approved back in the late 80s or early 90s for alcohol dependence. The brand name goes by Revia or Revia. The reason why that's considered to be kind of the regular dose or the high dose. The reason why it's specifically called LDN or low dose naltrexone is differentiated from the regular dose. And it actually has unique properties at the low dose that you don't see at the high dose, and kind of vice versa too. I mean, if you're using it for addiction, you don't want to use necessarily the low dose. It may not be very effective. You want to use a high dose, but if you're using it as an anti-inflammatory and a kind of an immune balancer, immune modulator, then you really want to find the low dose. And low dose is considered by many people to be less than 10. Some people say less than 15. And it seems to have 2 separate mechanisms of actions. One is a TLR, it blocks TLR4, in that way, it's a glial cell modulator, inflammatory modulator, so it reduces the inflammation from the glial cells, the nerves and things like that. It also it temporarily blocks the opioid receptors, and you get what's called a rebound effect, and it kind of does a feed forward loop to increase endorphins. And endorphin receptors are thought to be in many different parts of the body, the gut cells, the immune cells, and of course nerve fibers and things like that. So that's why it's thought that that opioid rebound is very important. By the way, I'll be giving a talk in the near future on LDN as a gerotherapeutic, as a potential longevity therapy, and I'll be diving a lot deeper into the mechanism of actions of LDN and why it has a promise to be kind of one of the next big things, I think, in terms of longevity therapy. So just a quick history of LDN. I consider that a lot of people consider Dr. Bahari the father of LDN. His work back in the 80s on AIDS patients, he saw that they had low endorphin levels, and he was looking for a therapy. As the story goes, he was looking for a therapy to increase their endorphin levels because he thought that was the key to helping them maintain a healthy immune system. And this was before antiretrovirals came on the market. So he's the one who kind of discovered that, hey, look, you can improve the immune function of these AIDS patients. And I think the antiretrovirals came on the market, I believe, in the early 90s. And so I think LDN just kind of got sidelined because the mechanism really didn't make sense. And it's not like an antiviral. You have a viral infection, you block with a virus. LDN was more of a kind of a roundabout way to do it to boost the immune system. So I think it kind of got sidelined. It didn't really go anywhere until 2007 was one of the first articles I was able to find on specifically on LDN at Penn State, Crohn's disease. 2009, Jared Younger, Stanford, he came out with the fibromyalgia paper. And then, recently, when you look LDN and PubMed, I mean, you'll see over 230 articles. And I didn't update the slide from 2 years ago, so I'm guessing there's probably a dozen, several dozen more articles. So we're probably up to 300 plus if we were to go back and do a search. There was a trial that was supposed to be ongoing here in Detroit, looking at LDN for acute COVID. I don't think it ever got finished. I'm not sure why. And then also there was a group that kind of beat us to it, so to speak, in terms of looking at LDN for COVID, but they only looked at just LDN. And they found what we found was that using LDN seemed to improve multiple aspects of long COVID. This is a graph from a company that used to be called Cure Together. I think they got bought by 23andMe. They did a survey on patients with fibromyalgia, and on the, let's see, where's my mouse here? So on the y-axis here is the effectiveness, and on the x-axis is kind of popularity. And you'll see a lot of therapies on here, like acetaminophen, Tylenol, exercise, and then funny enough, you'll see a lot of FDA-approved drugs for fibromyalgia like Lyrica and Cymbalta, and some very commonly used medications such as Effexor, Prozac, Wellbutrin, and these are Lyrica and Cymbalta are very popular medications, like I said, because they're FDA approved, but the effectiveness actually, according to this survey, is actually negative, meaning it seemed to be harming more people or causing the opposite effect. But if you look at what kind of tops the chart, like literally tops the chart on effectiveness, is low-dose naltrexone. I mean, funny enough, even more than Vicodin. So this was actually quite a surprise, I think, to the surveyors. This is 1,400 surveys. I don't remember what year this was. Must have been a while. Must have been several years ago, when Cure Together was still around. And of course, the other studies I talked about in terms of the Stanford study with improvement in symptoms with LDN and fibromyalgia. All right, so I'm going to kind of switch gears here to talk about NAD. NAD stands for nicotinamide adenine dinucleotide. It's a bit of a mouthful. I'm just going to say this last time I'm going to try to pronounce the whole thing. It's just NAD for short. It's a coenzyme involved in a bunch of processes in the body. You have NAD in every cell, and it's involved in several metabolic pathways. If you remember the Krebs cycle from high school, you'll see NAD and NADP kind of scattered throughout the entire cycle. So it's also it's very important in mitochondrial function. But one thing that a lot of people don't realize is NAD is actually kind of a direct fuel for many enzymes related to like DNA repair, cell survival, inflammation, and so mitochondrial and energy is only half the equation. The other half of the equation is maintaining cellular processes properly, housekeeping. So without enough NAD, cells start falling apart, so to speak, because these repair enzymes and these housekeeping enzymes don't work as well anymore. And as somebody gets older, it's thought that at the after the age of 50, NAD levels start dropping by half. And it's a combination of you're not making it efficiently as much anymore, and the other aspect of it, you need more. I mean, you need more NAD because you need more upkeep as a person gets older and kind of accumulates more damage. So the unfortunate thing about NAD, though, you can't take it orally. If you try taking it orally, it gets degraded in the stomach and just never makes it inside the human body. If somebody wants to try to take it orally, you have to take one of the precursors, like nicotinamide riboside or nicotinamide mononucleotide are kind of the main forms. Yeah, so you need to do a precursor. Niacin is another form as well, but I'm not a big fan of taking niacin to boost NAD for a variety of different reasons, let alone the flushing that some people get. But so if you want to do direct NAD, you either have to do an injection, an infusion, or we were led on to a nifty way of doing it using an iontophoresis patch. So this is a picture of the patch here. So I'm pointing at the wrong screen here. I got two screens going on. There's a picture of the patch here. Basically, it uses an electric current to kind of drive charged molecules under the skin. It's an FDA-approved device, usually used in sports medicine. Usually you'll see it coupled with various different steroids and other anti-inflammatory compounds, usually for joint health. So, if you have like a tendonitis of some sort, or a painful joint, sometimes sports medicine doctors or physical therapists will use these over a joint instead of doing a joint injection, for example. But we kind of repurposed the patch for NAD, and we had a compounding pharmacy compound a 400 milligram per ml solution. And the patch, with the wear time, the patch was 4 hours. Participants would have applied the patch for 4 hours, really anywhere on the skin. And just once a week was thought to be enough to boost NAD levels. Like I mentioned before, I mean, the reason why we kind of coupled, so I mean, like as LDN, long history of helping with inflammatory conditions and things like that. But we thought maybe that wasn't going to be enough. Maybe LDN by itself, because long COVID just seems to be a beast. So we thought, okay, if this is going to be a pilot, we want to have the best outcomes or best possible chance of having the best outcomes. Let's do a dual combination therapy. So we decided to add NAD to it as well. Again, there's also anecdotal evidence at the time. There's anecdotal evidence at the time when we first got started that people taking LDN were feeling better. And then there's also anecdotal evidence that people taking NAD were also feeling better. And so that's why we kind of combine the two together to give us the biggest chance of finding a benefit for people. So I mean, there's multiple reasons why we chose NAD as well. We talked about the SIRT1s and oxidative stress, and it was thought that boosting NAD levels would also help enhance the immune system to help fight off the virus, because like I said, one of the theories of NAD of long COVID is that the virus kind of lingers around your immune system, patient's immune system, just not able to get rid of it. Here's a slide I took from a gentleman. I put the link at the bottom where I took this from. These highlights are my own. So, the blue and the red are kind of my own highlights. Sorry, I take it back. The red is the author's highlight, and this highlights why NAD is thought to be useful because of because of kind of the mechanism here. Whereas I kind of put in the LDN, and I kind of circled where LDN would be useful when it comes to long COVID. So these are kind of like it's an infograph of what's thought to cause these long haul long COVID, and you can see that by kind of doing the combination therapy, you're hitting multiple aspects of the underlying biology of long COVID. So what did we do? So we when we enrolled patients, we started them on we provided the compounding pharmacy provided the tablets, and LDN is known to have certain side effects such as sleep disturbance, things like that. So usually it's recommended to start low and move up, kind of ramp up. We accelerated the ramp up process more quickly than usual, just because it was a 12-week trial. We didn't have 12 weeks to ramp up somebody on LDN. We went and ramped them up quickly to start seeing a benefit at the end of that 12 weeks. So we did a very accelerated ramp up process, and just for simplicity, we just sent the tablet and had the patients break them in quarters to start with, and then a half, and then a full tablet. But the patch was, you could just wear it. There's no half patches in this case. We at baseline, week 2, week 4, week 12, we monitored for side effects and asked patients to fill out the Chandler's fatigue scale and the SF-36. So we finally ended up publishing it, and we ended up publishing in the Brain Behavior and Immunity Health journal. And this is a link to it. This is you can download the PDF for free. It's a free access study. So let's jump into the results here. So what did we find? Well, before we jump to the results, our demographics and the characteristics. The mean age was 44.7, with a range between, our youngest was 28, our oldest was 69. About 30% male, about 70% female. And the time between COVID and the first dose was on average about almost 200 days. So a little over 6 months on average. But we had some people who we caught them pretty early, about a month into it. But we have other people who year and a half, almost 2 years after COVID, we were catching them. And vast majority of people were able to show us PCR, and some people had the antigen as they became more popular towards the end of the trial. So what did we show? So here's a table that shows baseline, 2-week, 4-week, 8-week, 12-week. And we started out with 36 at baseline. We had a couple of people drop out because people just drop out of trials for a variety of different reasons. We ended up with 23 people at the end. So there's multiple ways to kind of look at the SF-36, because there's, like I said, there's 8 domains. So each domain kind of gets its own score. If you kind of take the SF-36 as a whole, you get the mean SF-36 score. And that we started out, with an average of 36.5, which, if you remember, I told you 50 means average health. So these people were, the average participant in our trial was significantly less than average when it comes to health. And you can see that throughout the trial, there was a bump, up to 42, 42.9, and then it seemed like week 8 things really started to kick in, up to 50, and then 52.1. Unfortunately, there's only a 12-week trial, so it'll remain an open question whether or not, if we continue the trial for longer, another 12 weeks, would we continue to see improvement? I don't know, maybe. But it's also possible that people may plateau at some point. So again, this is why you do pilots. You do pilots to kind of like help uncover what may work or what may not work. So if you look at the p-values, that they're pretty, they're very significant here. There's a 1 that's cut off at the end here. For some reason I couldn't capture the whole chart. And you'll see basically for pretty much all the domains, pretty much all the domains, we saw significant value at week 12 versus baseline. If you look at, for example, mean role limitations due to physical health, we started out at 9. 9 is almost non-functional, dysfunctional, and we were able to take the average participant from 9.2 all the way to 39.1, which is still less than average, but that's a, what is that, a tripling, quadrupling of the SF-36 score. So that's pretty impressive, I think. And here's just some more kind of subcategories. They all met statistical significance, from baseline to week 12. Some participants, for example, I was kind of surprised that even though the average participant seemed to be very poorly physically functioning, their emotional well-being scores were not that bad. I mean, it started out average 50, 50.3, for example, emotional well-being, and it improved. It improved at a statistically significant, but in terms of like the number of points it went up was only about 13 points, which is not as impressive as some of the other ones that we saw. So in some domains, people did much better. In some domains, they started out at a decent baseline, and we didn't see that big of a difference. So these are kind of just kind of the breakdowns of the different domains that we saw. In terms of Chodler, again, with Chodler, the higher the number, the worse the person is. Remember, we enrolled people 9 and higher. So actually, we Chodler, it maxes out at 33. So we were enrolling on average about 26 score out of 33, and you can see how that kind of tumbled over time, from an average of 26 down to an average of 17. Again, you're very highly statistically significant there. This is kind of a radar chart showing kind of the baseline score, the 8 endpoints here, mean role limitation due to emotional, due to physical, pain is also captured, social functioning, emotional well-being. And you can see that pretty much the entire radar, the entire 8 domains expanded. Some expanded more dramatically than others. For example, like, for example, I would say this one expanded quite dramatically. The mean role for, due to physical health. Pain, a little bit. Emotional well-being, like I talked about, a little bit, but still, quite significant. Now we did see a phenomenon of, is almost like a duality. About 50 or 60% of our patients responded, and they responded really well. And about, I don't know, 40 to 50% of our participants didn't respond at all. And I wasn't really surprised about that. I was hoping to see more responders, but I wasn't really surprised about that number, because that's what we typically see when initiating LDN therapy for patients. You have I commonly say, patients who respond to LDN fall into usually one of 3 buckets: either kind of a super responder, they feel amazing, they sing praises for LDN, they think it's the best thing in the world, and then on the opposite end, it does nothing. LDN doesn't do anything. They don't have any side effects. They don't have benefits. It doesn't touch them. It just kind of bounces right off of them. And then, so it's about 1/3 on one side, 1/3 on the other, like 1/3 in the middle, where it's like, they get a little bit of response, but it's not a huge response. So it's kind of a limited response. And so I wasn't surprised when we saw that there was a group of participants who responded really well, and a group who didn't. So we kind of like broke down the numbers based on non-responders. And in this case, we kind of categorized like a 20% improvement in their scores as kind of being responder. Because it's not, typically 20% is usually kind of the number you'll see in most clinical trials when it comes to clinically significant responses. So not surprising here. I mean, you'll see that non-responders, didn't go anywhere with their mean total SF36 scores, whereas responders who started almost in the same range, they had a much bigger bump at 12 weeks. So you can see that the non-responders, started at like 25, if this is the mean bar average, and went up to maybe less than 40. Again, not really statistically significant if you look at the error bars. But if you look at the responders, they started maybe a little bit higher on average, but they ended up way higher. I mean, these bars don't even, if you squint, you might see that they cross, but they really don't cross very much. And so you can see we took the people who did respond, we were able to take them from being relatively poor health, based on their SF36, to almost, some of our participants were able to achieve SF36 scores in the upper 70s, upper 80s, almost like back to 100% functioning in many ways, again, according to SF36. So we did certainly have a group of people who were super responders. And so that the data on these more, responsive patients are actually quite a bit more impressive. And that doesn't always show when you average it out, because like I said, if you have a mix of responders and non-responders in the study, they kind of like, the non-responders kind of drag down the average, so to speak. So I think it's even more impressive when you look at the data for people who actually got a response from it. This is the Chodler again. I mean, not much difference when it when it comes to non-responders and fatigues and their fatigue score, but a big drop from from almost 25 down to 10 on average. And then a lot of people they dropped down to the point where they wouldn't even qualify to enroll in the study anymore. So again, I mean, there's some people who just do really well on LDN. I'm not sure. The unfortunate thing about the study, because we use the combination, I think we got good results, but there'll always be a unanswered question here, is like which one was carrying the weight. How much would have LDN done? How much would have NAD done by itself? And so that's why kind of the next step here would we were hoping that this pilot would kind of lead or spur more research into it. So if anyone runs a research institute or has access to the resources to do a follow-up trial, I mean, it'd be great. If things could be followed up on, expand it to more than the 20-odd people that we had. Expand it to looking at biomarkers, for example, so you could actually start confirming some of the the IL-6 and the TNF markers and things like that of inflammation, and some other markers that could give us better clues. And look at other modalities. I mean, these we chose the LDN and NAD based on what I talked about, but there could easily be others, like somebody suggested to us maybe ketone esters would help, maybe boosting glutathione as an antioxidant. Metformin has antioxidant properties, and has some promising results with inflammation and things like that. Maybe there's some natural supplements out there like turmeric and things like that. So we were hoping that this pilot would kind of spur more interest in research, and it also I think shows that that something can be done. I think when we launched the trial back, I think it was 2020, early 2022, I think, or maybe sometime in 2021, when we launched the trial, treatment was almost all geared towards symptom relief. I mean, you had pain, you took ibuprofen. You had shortness of breath, you used an albuterol inhaler. You had palpitations, you take a beta blocker. And so it was all just kind of putting bandages on the symptoms. And so I think we wanted to show that no, you can actually make a difference, potentially make a difference in the disease process. Of course, we don't have any biomarkers to back that up, but I think I'll be willing to bet money on that, though. If we actually could do biomarkers and repeat the study, we'd probably see significant changes in many biomarkers. So that's kind of what spurred us, and also it was in many ways a humanitarian effort as well. A lot of people were suffering and are still suffering from long COVID. And again, at the time when we launched the trial, not much was known about how to treat the underlying process. And then another thing I'd leave you with is the inflammatory process and the kind of immune dysregulation that we see with long COVID. It's thought to reflect accelerated aging. And almost like it presses the accelerator button on aging, and it's kind of a preview of what happens to somebody who ages prematurely. And so I think the fact that we could take a disease process or syndrome in this case, and maybe even reverse it for some people or improve it for some people, gives us a lot of hope that that we could potentially solve the more important problem of aging. And that's what we do at AgelessRx, for those who are not familiar. Okay, that's it for my presentation. Thank you very much for listening. I think we have some questions.
Yeah. Hey, Dr. C, thank you so much for this. Thanks everyone for hanging on. We will go through the questions. I think you answered many of them naturally in throughout your presentation.
Okay.
But we'll jump to a couple that definitely you I don't think you have answered.
Okay.
So do you, Brad asks, do you have any thoughts on other measured outcomes besides fatigue, like pain, any other secondary or outcomes for a potential follow-on trial or pilot study? Or do you think just fatigue and is the one to focus on?
Yeah. Well, I mean, uh, the reason why we chose fatigue, it was because it was first of all the most common. If you looked at, I think we looked at a list of the the top 10 symptoms. I've listed several, but when we looked at the list of top 10 symptoms, almost universally people had fatigue as part of long COVID. So that seemed to be the natural one to target because it was the one that most people had, and there happened to be this validated tool called the Toddlers. And there are other tools out there, but I don't remember why exactly, but we ended up choosing the Toddlers over the other ones. I think it was just kind of the ease of use, the ease of scoring. So fatigue was like the main one, and then if, as I mentioned in my talk, we also used SF36 because it reaches across a lot of health domains. Mental function, mental status, pain, things like that. So we did include several of those, maybe not in the level of detail that people would like, but like I said, SF36 is I mean, you can only have patients or participants answer so many questions before they stop answering. If I were to design a trial in the future, I mean, it's possible we could get people to do more surveys, more in-depth surveys. I mentioned biomarkers. I'd have to brainstorm a list of biomarkers I'd like to see. I kind of rattled some off, during the presentation, but there's probably a whole list of like inflammatory markers and immune function markers and things like that we'd probably look at. There's probably even markers. I mean, what I'd really like to see is more like an kind of a shotgun approach where you look at you do high throughput assays where you look at 500 or 1,000 metabolic markers or protein markers, proteomics, metabolomics, and just that let the data tell you what's significant or not significant among the baseline and the or among the placebo and the treatment group. So yeah, I mean, I'd love to see this data expanded. We don't have the ability to do that at AgelessRx, but I'd be more than happy to work with any other group that's willing to take this research up.
Awesome. Thank you, Dr. C. There were a couple questions. I think you did cover this, but just wanted to make sure, since a couple of people brought it up, there is no way for us to parse out the difference between LDN and NAD, right? We just did a combo therapy, and it's basically a known limitation of our study that we don't know, as you said, which one's carrying the weight. Just wanted
Yeah. I wish we did, but like I said, we kind of chose the double therapy just to have the biggest chance of having an effect. With the knowledge full well that if the study did succeed, we wouldn't know. But like I said, that's the purpose of pilot. And then you spur the interest with the pilot, and then you hope that somebody kind of picks it up and answers some of these more interesting questions.
Awesome. Let's hope that is the case. A few other questions on the one same kind of like umbrella. There's several questions regarding LDN doses greater than 4.5 mg per day. Do you have any thoughts about LDN at like 6 mg per day? Some people go as high as 9 to 18 based on this comment. How do you know when should you increase? Any thoughts or experience you've had with higher doses of LDN than the ones we currently prescribe at AgelessRx?
Yeah, I mean, one of the limitations of the study is the inability to kind of customize doses for individual participants. It just make a study way too messy doing that. But from clinical experience, I tell all patients who start LDN that 4.5 is a dose that seems to work the best for most people, but not everybody. Some people need less, because with LDN, more is not always better. In fact, too high of a dose, I mentioned like the 50 milligram dose. There's some reason to believe that actually that causes immune dysfunction, might actually accelerate aging instead of improve it. Although I don't have any evidence for that, but there was a mouse study going back to 1983 that looked at low doses and then high doses of naltrexone, and the mice were injected with cancer cells, and the high dose actually did the worst. So there you had the control, you had the low dose, you had the high dose. The high dose actually did the worst. So there is reason to believe, I mean, I don't know how that'll translate to human, but there's a reason to believe that if you go too high on your dose of naltrexone, it actually might have you start having opposite effects. But with that said, like I said, everyone's a bit individual. You know, everybody may need a little bit different dose. When I prescribe it clinically, you know, I start patients usually at a low dose, either 0.5 or 1.5. Most of the time 1.5, unless there's a clear reason to start lower for a variety of different reasons that I probably don't want to get into right now. So that's a whole webinar all by itself. But yeah, I start people low and I kind of have them pay attention to their response as they move up, and I call it the Goldilocks dose. And then we have an article and things like that on how, you know, to kind of guide or coach people into how to find that Goldilocks dose. So there's certainly plenty of people out there who need more than 4.5, and there are, you know, probably lesser people, but certainly people out there who do need who need less than 4.5. So it is a customizable, you know, personalizable thing.
Okay. Staying on LDN, is there a difference in effectiveness between LDN capsules and tablets?
I've never really noticed the difference between capsules and tablets. I've had patients swap back and forth. At AgelessRx, we only offer capsules, but when I used to prescribe it out of my clinic, you know, I've had patients try both, and I haven't really noticed the difference. In fact, when we first started prescribing LDN at AgelessRx, we started with tablets, and then we switched over to capsules, and people didn't seem to mind or care. Of course, there's always an exception. There's always going to be somebody who's going to send me an email or a comment or saying, you know, saying that they felt better on capsules or tablets, but just kind of, you know, vast majority of the time we didn't really see any difference.
Awesome. This is a pretty interesting question. Curious to see what you think, but why do you think that LDN and NAD seem to be effective for improving long COVID symptoms where many other therapies have failed? Is it like a unique mechanism of action? Something specific about them? Just curious, I guess.
Yeah, well, I mean, I would refer you back to one of my earlier slides. Again, I don't have time to go through the whole mechanism, but there was that very busy slide with that very busy infographic with kind of like, you know, the blue, you know, the LDN kind of circling the inflammatory markers and the NAD kind of circling some of the, you know, some of the other markers. So that I would encourage somebody to go back and look at that slide to get a better idea. But basically, I mean, it comes down to, you know, with LDN specifically, well, let me back up with long COVID and a lot of these kind of these syndromes. So the, you know, chronic fatigue syndrome is a syndrome. It's not really a disease. You know, it's this you know, this constellation of symptoms. You know, usually at the heart of these amorphous syndromes tend to be inflammation and autoimmunity, you know, at various different degrees. And one of the reasons why LDN seems to work so well for these kind of hard to pin down, hard to treat syndromes and diseases is because LDN, like I mentioned in my presentation, seems to help balance the immune system through that endorphin rebound, and also has a direct anti-inflammatory through the TLR4. So that's why I think LDN works so well. NAD, you know, kind of complements LDN in kind of some mitochondrial function, which seems to be a big issue with the fatigability part. I mean, you know, if somebody has significant fatigue, usually that means that they have some sort of mitochondrial issue going on. So boosting NAD tends to boost, you know, mitochondrial function, along with those housekeeping enzymes and repair mechanisms that I talked about in my presentation.
Okay. AgelessRx's very own Girish asks, any ideas why the other 50% of participants were unresponsive? I know you briefly touched on it, that some people just seem not to respond, but any thoughts as to why potentially?
Yeah, I mean, like I said, like I mentioned before, there's a phenomenon I've noticed, like almost from the first day I started prescribing LDN, you know, years ago. And it's a phenomenon that other clinicians, it's not something I'm doing wrong. A lot of other clinicians who prescribe LDN also kind of notice the same. In fact, that 30-30, you know, that third comes from Dr. Salibi, who's another well-known doctor who he's well-known among the LDN community. So I forgot to give him credit for that one third generalization. I don't know. It's been a problem that's been bugging me for years, and I haven't been able to find an answer. I have an idea on how to study it. Some people say genetics, but I don't know. I don't buy the genetics thing. Other people say, oh, LDN doesn't work by itself. I don't know. Maybe come back and check with me in a few years if I've commissioned a study to try to figure out what can help boost LDN's effectiveness.
Awesome. A question on hydroxychloroquine. Do you have any experience with it? Are you seeing any positive results from patients taking hydroxychloroquine or not really?
I
LDN
don't.
hydroxychloroquine.
Yeah, I don't prescribe hydroxychloroquine very
Okay.
often, so I can't say I have much
Yeah.
experience with it.
Okay. Totally fair. And I believe we're not re-recruiting necessarily for this trial, but a couple people are asking when we would launch the follow-up to the pilot study. I don't know if you want to comment on.
Yeah, no, like I said, we did this. We're not. We're not a long COVID clinic. We're focused on longevity and aging. So this was kind of a. We had a research team. We had these therapies we thought would be beneficial, and so it was more of, like I said, almost like a humanitarian effort that we took on. And now that we've kind of saw that found that there is hope, that there's potential treatment for long COVID. Our hope, our expectation was that somebody would pick up on it, with who maybe an immunology clinic of some sort, or rheumatology clinic of some sort, or a large hospital or something, who kind of take and run with it. So we don't have any plans to expand the COVID trial. Sorry.
Okay. A couple questions on rapamycin and LDN and NAD. Can you just combine it all? Can you be a participant, quote unquote? I know we're not doing a follow-up to this trial at the moment, but in theory, could you be a participant, or is rapamycin some sort of like exclusion criteria?
Well, we didn't. When we were looking at the inclusion exclusion criteria at the time, rapamycin was just starting to gain popularity. Not very many people were on it, but I think if we look at that graph that I showed you before, in terms of hitting that infographic, hitting the inflammation autoimmune with the LDN, and then hitting like mitochondrial function and other aspects with NAD. I think there's certainly room in there, and in other pathways that weren't even covered in that, to add other therapies. So typically, adding therapies can be beneficial. Not always, though. Sometimes they can be counterproductive. I suspect, based on my conversations with a couple doctors that I've talked to about this, I suspect adding rapamycin with LDN and NAD could be beneficial as a combination. I don't know if anybody's ever going to do that trial, though. Sorry, we're certainly not. But there's always an N of 1, meaning if somebody has long COVID, they want to try that combination. Let me know how they do on it. Of course, N of 1s don't always, make it into publication, but it's interesting nonetheless.
Okay, awesome. Question on NAD precursors. Would they be just as effective, or is there something special about direct delivery of NAD?
Typically with the precursors, again, back when we launched the trial, it seemed like people were underdosing the precursors. NR, and I think only NR was available at the time, if I recall. NMN was kind of a more recent thing. Usually the supplements would come as 200 milligrams, 300 milligrams, and you need to take substantially more than that for a variety of different reasons. It's degraded. When you do absorb it, only some of it gets converted. So since we've done our trial, there have been several studies that show that high doses of precursors, I think 1,000 milligrams, 2,000, I think there was one that opened to like 4,000 milligrams for the precursors a day. That does seem to have benefits across multiple domains. So yeah, I would say that, at the right dose, the precursors would also be beneficial.
Okay, awesome. People are requesting for the link to the paper. Do you think you can go back to that slide, or can you post them on the
Sure,
chat,
sure. I mean,
or
we can put in the notes.
yeah.
If you we can put it on our own website as well. So I think I don't know if it's up there yet or not, but if you go to AgelessRx.com/research, that link is here. I think we've published
Yeah.
our paper on there. If
And
not, we'll get it up soon.
yeah, we will publish this video in our YouTube channel, and we'll be sure to include the link to the paper in the description of the video. So that's one other place where you'll be able to find it. Another question on NAD injections versus NAD patches. There's a couple of those. Your thoughts on that?
Yeah, I mean, the reason why we chose the patch was more of a logistical issue, because we felt that a patch was just more amenable to a clinical trial, more standardized, easier to deal with logistically. You didn't have to worry about it being refrigerated or not refrigerated. And of course, we didn't want, some people are needle averse, or they're just not familiar with giving themselves an injection. So we decided on the patches just from a more logistical perspective. In my experience, some people like the patches better, from increasing their energy and things like that, physical activity recovery. Some people like the patches better, some people like the injection better. They seem to be interchangeable, as long as you kind of find the right dose that works for an individual person.
Awesome. Thank you, Dr. C, for that. There's a question. I don't know if you'll be able to answer this or not. There's just a few more left, and then we'll basically have answered all of them. But do you have any thoughts on the harms of Cymbalta lyrica that kind of like this treatment is not associated with? I assume that's specific medicines they're referring to.
Yeah, so I mean, I mentioned these medicines when I was talking about fibromyalgia and that survey. I mean, I don't think I said anything about harm. It's just the survey respondents seem to indicate that those medications actually had negative value, at least according to the survey. Now, I will say, again, having prescribed LDN to a lot of people with fibromyalgia and such, I have run across a lot of patients on Lyrica and Cymbalta, and some people do well on it, but it seems like the majority just don't for whatever reason. I mean, even the clinical trials are not all that great with Cymbalta and Lyrica. In terms of harms, I mean, I don't think I want to get into that right now, but there are, I mean, just like with any medication, you don't necessarily want to be on it for longer than you have to, except for medications that have been shown to improve lifespan and health span.
Okay. Can you restate what NAD dosage was used? What dose was utilized in the
Yeah.
trial?
So we had a compounding pharmacy compound a solution. It's 400 milligrams per ml, and you can only fit 1 ml on that electrode of the patch. So patients applied 400 milligrams through the patch. Because we didn't do any kind of NAD testing in this, we're not really sure how much people actually got. But 400 milligrams a week was a recommendation by one of our scientific advisors, and just kind of seemed like a dose that was consistent with better health.
Okay, awesome.
Again, that highlights the importance of maybe redoing this study, and maybe titrating NAD, so that should not, one of the limitations of studies like this is, you're giving everybody 400 milligrams a week, regardless of what their status is. You may need people who need 1,000 milligrams a week, and you may be people who, you may have people who have enough NAD. Although it's unlikely that somebody with long COVID has enough NAD. I think, based on my talk with scientists who've tested NAD in people who have a lot of symptoms, it seems like the more symptoms somebody has, the less NAD. It almost, I don't know what's the chicken and egg here in terms of like, does low NAD cause the symptoms, or does the disease process deplete you of NAD? I'm not sure, but it seems like boosting NAD levels to an optimal level seems to help with symptoms based on other science that I've seen.
Awesome. Based on just a follow-up on that, Dr. Civics, I think you were touching on it. assuming someone were to say take the baton and run with this study
Mhm.
and study LDN plus NAD further,
Mhm.
what are some of the things you would like to see in this hypothetical follow-up study?
Yeah, I mean, first of all, I'd like to see, I think before another study would be launched, maybe kind of looking, now that we have better tools to measure NAD, I think I'd like to see maybe a more in-depth analysis in terms of, what are some of the biomarkers and things like that are associated with long COVID. And I think there are some papers out there. I mean, I don't follow the long COVID literature all that well, but I have run across some papers that, have elucidated some of the biomarkers and things like that. So I mean, doing a little bit deeper dive on that, including, I don't think anybody's looked at NAD specifically for long COVID. So I think that should be kind of tested before somebody jumps into another study. And then having multiple arms of the study, NAD in one arm, LD in the other, combo in a third arm, and maybe a fourth arm would be placebo. I think placebo is an important arm to have in these sorts of studies. Or maybe I don't think a crossover would work very well in this study, because in my experience, I think these patients who got better, their symptoms improved. I think their symptoms improved and they stayed better. I don't think a lot of them regressed, although we don't have that follow-up. But I think from what I've heard from a few of the participants, they continue to improve. I think once you break that cycle of inflammation, continue to improve. Anyway, kind of going off topic here. I mean, I'd like to see biomarkers done, like I said, proteomics and metabolomics, things like that, NAD levels. It'd be nice to get maybe some kind of titration schedule here, to titrate people on NAD, titrate people on LDN to find the more optimal dose. So there's a lot that could be done here.
Okay, just last few questions, Dr. C. I think we're gonna be almost finishing on time. We cannot give any individual recommendations or personal health advice, so basic disclaimer. But there's a question concerning like just kidney function and I guess presumably liver function if you're taking LDN, metformin, rapamycin, all of the above. Is there such a thing as quote unquote overloading the system?
Well, first, naltrexone, if you look at the kind of some of the literature from the drug company, the original drug company who got the original FDA approval, and the FDA itself, there is a warning on there for liver issues, but you have to remember that the original studies were done in alcoholics who have very challenged livers to begin with. From what I've seen, I've never seen that pan out in any follow-up studies. In fact, there was a case report of I think a 26-year-old female. She was given a 30 tablets of the 50 milligrams, so 1,500 milligrams of naltrexone for her addiction issues. And she was desperate. She swallowed the whole thing, and nothing happened to her. I mean, I think she felt ill for overnight. She was observed overnight and was sent home. So I've never seen any issues with naltrexone and kidney issues, especially low-dose naltrexone kidney issues or liver issues. Metformin is not hard on the liver. A lot of people have that misconception. In fact, there was recently just this trial that came out that showed that actually helps protect the kidney function in diabetics. So it's not hard on the kidney or the liver, as far as I know. Rapamycin, again, as far as I know, doesn't directly have any damage to the liver or the kidney. But of course, you always want to exercise caution and combine medications under medical supervision.
Okay.
Yeah. But I don't see anybody having any issues with those three. I know I think we have some patients on those three combinations, and so far we have not seen any problems. Of course, again, there's not medical advice, but that's just my experience.
Awesome. There's a couple of questions just around sourcing of NAD. The person said that in the ketamine clinic, it seems to be extremely expensive. Is that the type of places where people get NAD, and can you source it from somewhere else? And then there's another question in that similar vein around a practitioner wanting to supply NAD besides IV and seeing if you can just like contact compounding pharmacies or ways to source
Yeah. For
NAD?
both of those, I'd encourage you to contact me directly or contact AgelessRx directly for those questions. I mean, we work with partner pharmacies, and as far as we don't have a monopoly on these partner pharmacies. So for practitioners, if anybody wants to reach out to me, I'd be more than happy to give them information on what partner pharmacies we use, and so they can supply it to their own patients. For patients, there are services out there now that are providing NAD, including AgelessRx.
Yep.
And it's become a lot easier to get access to those products.
Awesome. Last two questions, Dr. C, and then we're done. But can you drink alcohol in moderation, say 1 or 2 drinks socially, only occasionally if you're on IV NAD and LDN 3 milligrams or some sort of an LDN dose?
I'm not aware of any issues with small or moderate amounts of alcohol with either an NAD or LDN.
Awesome. And then have you seen anybody had IBS symptoms after having COVID?
Yeah, for sure. I mean, COVID itself seems to set off this inflammatory response, all sorts of things. I've seen people, have a flare up of their thyroid issues, or they have a new onset of thyroid issue after COVID. In fact, these days, whenever I see, a patient with a rare condition, I'm like, did this start after COVID? And you'd be surprised. Some people say, yeah, it did start, weeks after my COVID infection. Again, I don't know whether it's causation or just happens to be a coincidence. But there does seem to be something about, having a COVID infection, that does seem to set off this inflammatory, and that includes, GI issues. I mean, again, I mentioned that long list. Fatigue was at the top. I don't remember exactly where GI issues were, but I'm sure it's at the top of the list there.
Awesome. That's it, Dr. C. Think we
Okay.
covered it all. Thank you, everyone. We'll make this recording available in our YouTube channel as soon as our marketing team goes through it. And I just appreciate you, Dr. C, taking the time. Any last words?
No, well, again, I mean, if anybody has the capability of taking the study and expanding it, I'd really love to see it expanded.
Awesome.
All
Thank you,
right.
everyone.
All right, bye all.